two guest speakers we have today, Dr. Ravijit Singh and Dr. Kiranjit Singh. It's our welcome, sir. It's our privilege to have you here.
Thank you, sir.
The reason for them, we wanted to have a special edition dedicated exclusively for iris claw lens among our weekly meetings. And I thought there was nobody better than these two people, because the amount of experience they have with these lenses has been enormous. They've been using these lenses since decades. And I asked them to send a CV, and both of them did not send. Both of them did not send the CV. So I made up my own thing. I'll be speaking for them here. And Dr. Ravijit Singh is a comprehensive ophthalmologist and excels in cataract surgery, refractive surgery, and glaucoma surgery, to name a few. And Dr. Kiranjit Singh is an excellent cataract surgeon with special interest in postipolar cataracts. And I'm happy to say that I've used his oval rexus technique in these cataracts, and it's really a nice little trick. And I would advise many of you to just go and try this. And he was very kind enough to show me around the hospital. This is the place which they work, the Dr. Daljit Singh Eye Hospital in Amritsar, India. Last year when I visited him, very kind enough to take him around. And of course, they have the daunting task of carrying forward the legacy of the great Dr. Daljit Singh. And they have been doing it with great aplomb, I must say. And of course, both have been groomed to think differently, think originally. And they had the privilege of having the insight into Dr. Daljit Singh's mind, who was undoubtedly one of the most original thinkers and brilliant thinkers among all the eye surgeons world over. And the iris claw lenses were one of this hospital and these surgeons were one of the most early proponents of using iris claw lens as a treatment modality for aphakia, when none of the other surgeons in India were actually using it and were not even considering it. The iris claw lens have become popular over the last decade or so, but these people have been using it for ages now, and they have all the vast experience to teach us and to deal with how to implant it, and also how to deal with the complications if at all we have. So it's indeed our pleasure to have them with here, and welcome you, sir. And with this brief introduction, we'll start our session. We also have our host faculty here in the form of Dr. Mallikarjun Hiralgi, who represents Sankara Eye Hospital. In South India, they were the ones who have the maximum experience with the iris claw lenses. So I thought he's an apt person to speak up, share his experience. And of course, we have our dear mentor, Dr. M.S. Ravindra sir, who will be sharing his few practical pearls with us. So thank you for joining us all, and let us start the session. May I request Dr. Mallikarjun to share his screen and start his presentation now. Dr. Mallikarjun, start your screen share. Dr. Mallikarjun, you are there?
I think host has muted everyone. Is it so?
No, you are audible. Okay, yeah, he's starting.
Mallikarjun sir, unmute yourself.
29%.
Is everybody hearing well?
Yes, sir. We are able to hear.
Okay, Dr. Mallikarjun
has to
unmuted himself.
It's not unmuted still.
Hello?
Mallikarjun?
Yeah. Now I am audible?
Yeah, yeah.
Sir. Yeah, you're audible, sir.
Okay.
Go ahead.
Yeah, actually, the journey of posterior iris claw lens started in somewhere between 2003 and 2004 in our group of hospitals. After one of our senior consultant attended the APAO conference in somewhere in Thailand, I think so. And he saw a presentation on fixation of the iris claw lens posteriorly. And he was very much impressed by the procedure. And from then we started doing all this iris claw lenses. And initially we had definitely we had all the inhibitions, and we were thinking how to fix it posteriorly, how long it will stay. And we didn't have actually the lenses actually made for the posterior iris claw implantation. And initially we used the artisan lenses, which was made for the anterior claw lens implantation for posterior fixation. And whenever after that we learned something and started presenting in conferences and CMEs, and the expectancies were very low, and everyone was telling what you are doing. You are putting the lens behind the iris, and it may drop down, and you are putting in a pediatric patients, and the acceptance was very low. And but we had some confidence that it will going to stay, and it would work. And later the Indian company started manufacturing these lenses with the help of our senior consultant. And initially we had a big size of the lenses, but it was difficult to enclavate such lenses, because when the haptic comes near the angle, it would be difficult to enclavate. And we made a little bit smaller size. The size became very small, and it was not suitable for all the cases. And at present we are stick to this lens, this type of lens, and it is overall length is 8 mm, and 5.5 is the optic size. Dr. Deepak asked me how many numbers we have done, but if I try to find out, it was a very huge number, but I don't want to tell it because I can see we are one of the biggest users in India. I cannot say we are the highest user. There are masters are there already here, but I can say we are one of the highest users in India. And nowadays, almost all surgeons use the iris claw lenses, and we have stopped doing almost all the other type of secondary IOL, and very few surgeons who are not trained in iris claw lenses and which they join in our group, they are doing other type of iris claw lenses. Initially, we had some surgical, I can say some our experience in surgery. And initially what happened, we used to implant the iris claw lens, putting it whole lens behind the iris and enclavating it one side, and changing the hands and enclavating other side. And it was not so easy for us to do such that type of procedure. And we had some difficulty. Then we learned from our mistake, and what we started enclavating it one side first, then other side would be on the iris plane, and enclavating it other side. That made this procedure very easy. And talking about whether should we do PI or no PI. First, initially we used to do PI in all the patients, and and afterwards we stopped doing PI, thinking that there is some space behind the iris and the lens, which would allow the aqueous to flow, and it would not lead any problems. But some patients, they came with pupillar fog after some times. Now we do PI in all cases. Advantages of this posterior iris claw fixation of ILS. It's a very minimal learning curve is there, and only you don't need extra instrumentation, extra flap creation, all the other sophisticated instruments. We need only extra one iris holding forceps and the modified Simsky hook. And we have not seen much glaucoma by the iris claw lens. I mean posterior fixated iris claw lens, no UJ syndrome, no chronic uveitis, no corneal decompensation. And late dislocation, but surprisingly, I have not seen my personal experience. But I don't know whether in some centers of our hospital they have seen, but my personal experience, I have not seen any late dislocation of this lens. And I have a personal longest follow-up of 14 years of this lens, posterior fixated IOLs. Indications, if you think surgical aphakia, where there is no PC support, traumatic cataract, maybe in adult and pediatric cataract when there is no PC support, sublactic lenses in pediatric as well as in adult patients, nucleus drop, IOL drop, in some other tricky situations like coloboma iris, and also we have implanted in the keratoplasty like a PKP along with iris claw lenses, maybe as a primary procedure or a secondary procedure. And we also implant in patients with previous ICC where there is a superior SI, and some other tricky situation like patients who has a ICC with very small iridodialysis, and still we can fix this iris claw lens posteriorly. What I say to my people, my students, you don't, in such situation, you don't need to do PI and TTS work. And complications, what you've seen. And if you see the complications are very few, I'm not exaggerating, very few. Beginners will have some, beginners will had some complications like IOL drop and one side enclavation and other side drop. This problem used to happen when we are implanting the lens, when we used to implant the whole lens behind the iris and enclavate both sides. And sometimes we are seeing decentered IOL. This used to be the older technique when we are doing that. And ovalization of pupil is common in inexperienced surgeons, but it does not affect on the vision. And pigments on the IOL, especially in traumatic cataract, does happen, but it does not lead to any glaucoma. And CME is the one thing we have to consider. It depends on the indication of surgery. If it is a planned surgery and planned posterior iris claw lenses, it is as good as a normal cataract surgery, but slightly high in traumatic nucleus drop and in IOL drop or uveitic cataract. And in I think regular IOLs also, if you place in the bag lens also, it will be CME will be there in such cases. And in such cases, you have to treat the CME and also you have to give a prophylactic treatment and also look for the CME post-operatively. And our few cases, we had our retinal detachment, and compared to the whole number of the surgeries, the incidence of RD is negligible. And few people may, some people may be thinking who want to start this iris claw lenses, whether I'm doing ethically or is this illegal or is it a negligence or and there are so many peer-reviewed articles have been published in the literature. These are some of the publications from our group. This is from a Guntur retrofixation of iris claw lens in visual rehabilitation of aphakic eyes and pupillar fixated iron intraocular lens in a pediatric subluxural lenses, and after a parspinal vitrectomy in a nucleus drop and IOL drop. I'm not going in detail because time doesn't allow me. And some more publications were implanted in pediatric patients and pediatric traumatic patients. And also we have compared the iris claw lenses, posterior iris claw lenses versus the regular lenses in a pediatric quarter. But we found in all these studies, we found this posterior iris claw lens would be better than other type of secondary IOLs. And one more important one doubt comes to everybody's mind in the beginners, whether pupil will dilate after the posterior iris claw fixation of iris. Definitely pupil will dilate. You can do a VR surgery, you can do a laser, you can do whatever you want to do in the posterior segment. And see, this is how this is how you can achieve this posterior iris claw lens. And this picture shows there is a you can see the haptic coming outside, and we should not intend for this, but still this is, if it comes out, it is a good de-enclavation because a lot of good amount of tissue has gone inside the haptic, and it is we consider it as a good enclavation also. And this is how we try to achieve, this is how we we have pupil ovalization is a common problem, but it doesn't affect on the vision unless the iris, IOL comes out of the pupil. And we have done implanted during PKP as a primary procedure and later procedures posterior iris claw lenses. And this is a traumatic cataract is where where there will not be any posterior PC support. This iris lens would be a very good choice. And this is the one case where this is aphakic glaucoma, where we have implanted valve here. You can see the tube here and iris claw lens. And coloboma iris. Here the pupil is dilated to show the iris claw lens here. And this is the case with the previous ICC, superior SI, iris claw lens has been implanted. And this issue won't come if there is this pupillary aphakia, pseudophakia issue won't come because this part would be covered by the upper lid. And this is a small video to show how to implant. So first you have to implant the whole IOL on the iris, and you have to place it in the correct position where you would like to implant it posteriorly. So here you see, then you have to mentally imagine where exactly you have to enclavate it. And I have made two paracentesis here. Then with the help of posterior iris, place it one side behind the iris and a modified Simsky hook. Feel the depression there and just a small downward movement, you can tuck the iris claw lens and form the AC, and other side again, it is placed behind the iris and it is tucked to the iris. Actually, that's it. To conclude, if you have learned this procedure and you are doing any complicated surgery and you have a intraoperative problem and don't lens in your.
Thank you, Dr. Mallikarjun, for the excellent presentation and sharing your experience. May I request Dr. Kiranjit sir to just start sharing his screen and begin his presentation. I would request all the delegates who are attending this, please note down or write down the questions in the chat box so that we'll have the discussion at the end. So most of the questions would be answered during the presentation, but you still something more, we can always discuss them at the end. So please do that. Dr. Kiranjit sir, you can. Mallikarjun, you have to stop sharing your screen. Dr. Mallikarjun, you have to stop your screen share. Kiranjit Singh sir, we're not audible. You're not audible. Unmute yourself.
Is it fine now?
Yeah, you're fine.
So I'm going to talk of iris claw, and my favorite is anterior iris claw fixation. So my slide is not moving.
Sir, there will be one arrow mark on the screen. You can try, sir.
So it should move now. So firstly, little iris by Dr. Singh was had a claw slightly placed upwards, and according to me, that was the cause of pseudophacodonesis, and which caused uh, endothelial cell decompensation in 10% of cases. But looking at the number of cases he did, around 150,000 cases he did alone, and the patients with problems that went very high. So 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 I had as far as I am concerned, I have been using small iris back. The patient came and his endothelial count was 2200, and after PRK his uncorrected vision was 6/6. So that led me to think that it is not because of the iris claw lens that we had corneal problems. It was because of the wrong placement of the claws. So initially, when patients used to come to me with some corneal problems, I was instructed to do a PKP with the exchange smaller version, and the patient started doing very well. But the problem is, after some time, the patients stop using steroids and they come back to you with rejection. So then I stopped doing keratoplasty, and the trend of DSEC had not started yet. So I just used to exchange the lenses. From bigger lenses, I used to put a smaller lens. And within few months, the cornea used to clear up. So that gave me a lot of confidence. So this is the first case. I exchanged the lens with a smaller version, put the patient on glycerin and hypersol ointment, and the patient remained with 6/6 vision for the next 4 or 5 years. Later on, he had a corneal decomposition. Then I sent the patient to Dr. Fogla for DSEC. And 10 minutes before the operation, I asked him, what is your game plan? So he said, I am going to take out this iris claw lens and put a scleral sutured lens. So I requested him not to do anything, just do a DSEC. And this patient has had got this DSEC done, I think around 10 years back, and he is stable with 6/6 vision till date. So amount of iris you are enclaving the claws, that is very important if you are enclaving it anteriorly, and that will have more stability. And you should have many sizes of iris claw lenses available in your OT, not just the one design. So the previous speaker was talking about ovalization. Ovalization occurs when you are putting a bigger lens, and when you are trying to enclave the iris, it is the iris medial to the claw which gets stuck into the claw. That is the cause of ovalization. So how to avoid ovalization? You should have smaller lenses with you in the OT. Then this thing will not happen. So I'm going to show you some scenarios where iris claw lens has bailed me out like anything. So the patient comes to me with an endothelial count of 500 with secondary glaucoma due to pupil block because of angle spotted lens. What I do a YAG laser, PI, and post the patient for a lens exchange. So this is after I have exchanged the lens, did a PI and did a bit of anterior vitrectomy. And after a month or so, I sent the patient to my friend Dr. Vikas Mittal for DSEC. And the patient comes back with this. I think the slide is not in my control a little bit. Uh, So he comes with this. Okay, we can leave it. So this is a anterior fixation in a child in which vitrectomy and lensectomy has been done. And how I do the anterior fixation is, firstly, I have a forceps with a longer limb. The limb of the vertical forceps below should be longer than the upper one. And you hold the on the shaft of the trachea. Then comes microcorneas. This patient was referred to from other hospital because the surgeon could not implant the lens in the capsular bag because the capsular bag was very small. So he just enlarged the incision and sent back the patient to me. So after a month or so, I did a very small sized iris claw lens implantation. And you can see that horizontal line up there. That is the line from where he explanted the lens, the previous surgeon. And from that, you can imagine the size of this eye. And now the child is in the cricket team of the school because of this. So this girl comes to me with a spectacle number of plus 20 diopters, and there is vitreous in the pupillary area, there is vitreous in the anterior chamber, there is vitreous in the wound. This is how it looks. So I just did an anterior vitrectomy and removed the vitreous from everywhere and put a lens very small in size next to the pupillary edge. And look at the smile on child's face. This again is a case of coloboma, microcornea, and secondary implantation. The power of the lens which was put was 42 diopters, and the patient had 618 vision thereafter. So this is a case of microcornea, coloboma, and black cataract. So I had to cut open the iris from the superior side and then implant the iris claw behind the iris. So this patient comes with to me with a painful eye because of the posteriorly vaulted ACIOL. Uh, and look at the size difference between the angle spotted lens and the iris claw lens. So I exchanged the lens, did a little bit of vitrectomy and the membranectomy, which developed because of the angle spotted lens. And the patient did not have any tenderness or pain after that. So this is a megalocornea. You see, the lens, iris claw lens, holds the eye with the by getting clipped to the iris. Eye is in a cornea, healed corneal ulcer with cataract. So what we do is we simply do a extra cap surgery and implant the lens behind the iris. So then we come to pseudo exfoliation cases. So I have done the phaco and I can see the capsular bag is not fit for PCIOL implantation. It is not sensible to keep this type of bag in the eye and put those segments and CTRs and rings, Sioni rings, and drill holes in the ciliary body and try to fix them to the sclera. Just take out the capsular bag with a non-tooth forceps and you won't be disturbing the anterior vitreous space also. After you are done with this, you can remove the hooks, and then it is your discretion whether you are going to implant the lens on the iris or below the iris. Done by me. Transplanting a retrofixation lens for the beginners is that you should pass a suture through one of the claws, and then you should try to do in the initially first two cases. So it will give you confidence that the lens is not going to fall down. In case it does fall, you can always pull it up with a suture. So you have to do a iridectomy. That is a must. So this is what I do. I do anterior fixation and bigger chunks of iris I put in the claw. So this is a girl whom we implanted an PCIOL with 55 diopters power, And after we had done that, she again came with a refractive power of 5 diopters. She was a high hypermetrop. So we implanted a lens to the back of the iris, and ultimately she became emetropic, 624 vision, and got happily married after that. So this is a patient who taught me so much. His patient prolapse, and the doctor just cut the vitreous with the scissors and put an angle spotted lens in the eye. So he came to me with a nearly decompensated cornea. So what I did was I explanted the lens, did vitrectomy, and I put a iris claw lens in his eye. So he did not show up for the next 3-4 months. So so meanwhile he went to another doctor in the city. So he told him all your before that, I was giving him glycerin drops, hypersol drops, and he was having 6-9 vision with very poor endothelial cell count. And he went to the doctor. He said, all your problems are because of this iris claw lens. So I'm going to remove this iris claw lens. He was a very, very nice patient. He said, go ahead. So he took out the iris claw lens. And in doing so, he pulled out a lot of vitreous and invited a lot of iris into the wound. So from there on, he went to another VR doctor. He said, go to a keratoplasty surgeon. So he sent the patient to Dr. Vikas Mittal, who's in Ambala. So he said, I can try something on you, but you have to go back to Dr. Kiranjit Singh, who will implant a iris claw lens so that I can put some air for the tamponade. Uh, but there were a lot of synechias and vitreous. So he rang me up, Dr. Vikas Mittal. He said, I think it's a very hopeless case, and even if you try to break those synechias, try to put a iris claw again, and those synechias are going to form again. Oh, I said, don't worry, you send the patient across to me. So what I did was I put the claw in the direction of the synechias, did vitrectomy, separated the synechias, and put all those synechias in that area. Hospital for, I think, his seventh surgery, and his DSEC was done, and he's maintaining 636 vision. So this patient taught me so much that I innovated a device. So and I applied that device on this patient. So this is a girl, 22 years of age, and she comes to me, um, and she says, we have been to all hospitals, and everybody has said nothing can be done about your eye. And her IOP was around 37, with all anti-glaucoma drugs, with Diamox and occasional mannitol, and there was a synechial angle closure. And I am not basically a cataract, a glaucoma surgeon, but I was working on the device after the previous patient's or adventure. So I told him, okay, I'll do something for you. So what I did was I uh, gave the main incision, multiple claws, multiple stabs in the limbal area, and under visco, I tried to separate the synechias. I think this is not the right way of doing it. One should do a gonioscopy. One should pupil small. And she was suffering from this glaucoma for the last 1.5 years. She was roaming around with a tension of 40, 45, and this is the device I made, and this is nothing but a ring with 5 claws, and I forcibly put the peripheral iris into these claws at 5 different places. Now, when I'm going to transfix the third clause, you see that black spot that will move inwards to give you a proof that something is moving towards the pupillary area. So the hidden, this PI also moves in. So I'm able to pull the iris, and after doing this, I did her second eye also, and she was a steroid responder. and she had already got a cataract surgery done and glaucoma surgery done for steroid induced cataract and glaucoma. And after 1.5 years, she's 13 getting patented in India. So I have done around 12 cases more of similar cases, and all are below 20. Some are with medicine and some are without medicines. And all were between 35 and 45. And all were hopeless cases, and I did mercy surgery on them. So this is the second device we are getting patented in a few months time, and this patient comes to me with a very long scleral tear repaired elsewhere, and you see the that iris is missing. So what I do, I have got this device made, colored iris segment, simply fix behind the iris, and patient will not have any photophobia after the surgery. This is a similar case I'm going to show you. So this is a patient with nail injury. So I am doing his phaco, but the iris on the opposite side is missing, and he's a young guy driving motorcycle, and he's going to have glare and photophobia, a lot of it. So, and he had, because of injury, he had a cylindrical error of 6 diopters. So I had especially got a toric lens made for him, and when I am through the cataract extraction, this toric lens, and if ultimately he got emetropia because of this toric lens, but because of the iris missing and missing in that area, he would definitely have had photophobia. So the toric lens is dialed in the plane, desired plane, and after constricting the pupil, so in future we are going to design it in a better way and have colors of different law, and same is done on the other side. So these are the Clayman forceps, and these are favorite of Dr. Ravijit. So I have started using them. So the patient comes back to me 2 hours after surgery, and I send him to the refraction room. His vision is uncorrected 6 by 6, and I take him out in the sun. He doesn't have any photophobia. I think that is all for today. Thanks a lot.
Thank you, Dr. Kiranjit Singh. I think that was a very enlightening presentation. We came to know about so many things which we were not aware of. I'm sure we're going to have a lot of questions. At least I have a lot of questions. May I go to the next presentation? May I request Dr. M.S. Ravindra to start his screen share? Sir, Dr. Kiranjit, can you stop?
And Ravinsis from staying with them for a couple of days and had free entry to their operation theater. And it was an amazing experience. That's the time I picked up not only the iris claw lenses, but everything about so many aspects of ophthalmology. And in addition to that, how one should lead a life, in a very satisfactory way. They're all of them, everybody is in their house. That's extremely a lot of innovative work, and I'm so glad that they have come to Karnataka to deliver this. I'll brief as to what exactly I do. Hope I'm visible and my video can be seen. Patient there directly with the 2.8 keratome, did a rexis, enlarged it. This patient had large zonular dehiscence, and the entire cataract capsular bag was removed, and he had intact hyaloidal face. And all kinds of iris claw lenses are available ready, and I just exactly perpendicular to this area, wherever this is the temporal cornea, and this is exactly 90 degrees away. when I enter the limbus here, I start in the peripheral limbus or even in anterior sclera from the tunnel introduce a cannula to enclavate it. There is no corneal folds here. So visibility will be very good. It's a very short tunnel made of about 23 gauge sharp keratome. And if I, this was not planned for the iris claw lens, this is a little longer. But if I'm planning for an iris claw lens, this tunnel also is going to be about 5.5. Take I have not done I have not taken a vitrectomy, so I am supporting behind with a the dialer, and I'm perforating it with a 23 gauge needle that forms an adequate size, and the hole is dilated there. This step is very important. Once I had now one portion, you don't have to pass your cannula there. Just move it, see under microscope if that moves. That means the slit is intact. So now I'm when you hold the IOL, do not coat with viscoelastic. If you coat with viscoelastic, it's a very slippery lens. It will jump everywhere. The whole, and I put a lot of people larger or a little smaller than normal people is all right. Don't put pilocarpine initially and then hunt for all those things. Keep the lens ready, and then you put pilocarpine. The moment it reaches here, it should not constrict too much. If it constricts too much, then you'll have difficulty in passing it behind it. So about 4 millimeter. This is probably about 3 minutes ideal, and that's how to put it there. So it doesn't exactly there. Form the chamber. The moment you take a fast steps, there is some amount of visco is going to come out. So you'll have to be absolutely quick, ready with your. This is the forceps. I like it. I'll show you later. As Kiran said, solid when come to the top of it. So where I hold it, I don't hold the center. I don't have a control. So I hold it somewhere on the left side and right side. This part I hold it at that point. This is the exact point I hold. See, as you can see, the forceps is separated by the thickness of the lens, and now it's you can see they are equally tipped. There is no elongation of the lower one. So now quickly go below it. There's some shallow blood there will help you exactly where you have to go inside. You should not cause a descent. So you can put this first and then put the lens, and then the haptic can be seen through the iris when you lift it up. You're not only taking it behind, after it goes behind, just lift it up, elevating the iris by a few, less than a millimeter. Then you can see the enclave. And it's a very quick surgery, as you can see. Inject viscoelastic. Now, here I'm going to struggle because this is a cannula which is a little longer. That's going to touch my lid because it's 12 o'clock and 6 o'clock. It's going to touch. You see what I'm doing now. I've gone there. See, this is touching the lid. It's difficult to angulate it and go inside. See, now it's difficult. Now, I have shifted over to another visco irrigation aspiration is absolutely important. You're not involved the vitreous, you're not involved the ciliary body zone. It's a quick surgery, and that's the end of your surgery. Remove all the viscoelastic, and that's it. Form the chamber. There's no need to bandage, no to hydrate the wound because I no. So I'll quickly in a minute's time I'll run through the slides. This is time tested. It's been used by Dr. Daljit Singh. I'll give the credit for him for introducing here. And lens and this is a vitrectomy done. Eye is going to be hypotonic, so you'll have to have positive pressure inside the eye. Many times it's created by the infusion through an AC maintainer. If you do a vitrectomy, the other one also, the pars plana entry also can be done. Inject dispersive in the anterior chamber, and you even by soft shell technique, more you press on the tunnel floor, more viscoelastic, and you'll be actually quick in doing it. Haptic contour shows to the iris and enclavate with 27 gauge cannula. Initially, I tried to enclavate as standard. They were taught with iris hooks. I've tried to do that, but iris hooks damages the iris there. So what I've done is have filament. these are the various forceps available. That's the forceps I'm going to use. This looks like Alice Macpherson's forceps, but the angulation is not anteriorly, angulation is to a side. This is my favorite one. I call it as Daljit Singh forceps. I do not know whether he has invented it or he has used it. It's called by that name. So this is done many times. It has been useful to everyone, and I'm very keen to learn about what Ravi has to say.
Thank you so much, Dr. Ravindra. It's a pleasure listening to your comments on iElite. You're
परेश माझा जो आहे ना
so
वेबिनारवर तो
knowledgeable
फोटो
about
चांगला
everything.
घालूया.
And Dr. Magur, it's again a pleasure looking at your videos that you have created. They are masterpieces. Thank you for sharing all your videos with us. Okay, so I'm going to share my screen. My presentation is in 3 parts. And also I have to thank Dr. Mallikarjun. He's done a good job of his presentation, and he's done my work very easy, because he has shown quite a few things that I had to show. Is a video on my technique of implanting the iris claw lens. I have been amongst the iris claw lens since 1976 or 77. And this is the claw of the lens in high magnification. And these are the different sizes of the lenses which are available with us in our OT, from large to medium to small and even smaller ones. And these are the right and left Clayman forceps that I'm very fond of using for retrofixation of the iris claw lens. As Dr. Ravindra mentioned, we need to check for the beginning of to know how the claw. Take a few lenses, no problem. At least you'll have no problem while you're operating and implanting these lenses. Another thing that I'm just about to tell you is that once the claw goes back, as Dr. Ravindra mentioned, it is difficult to find where the claw is. So if you hold with this forceps, the right angle of the forceps points towards the claw. So even if the claw is hiding behind the iris, you can find the place where you have to enclavate it. This is one of the older lenses which had been implanted entirely about 25 years ago. It has sadly subluxated. So I'm going to explant this and exchange this with a retro-ICL. And I've made 1 paracentesis on the right and 3 on the left. The reason why I've made 3 on the left is so that I can do a perfect centration of the lens. First, I fix the right claw, and then I let the left claw rest on the iris, and then I see which of 3 paracentesis will lead to perfect centration of the lens, and then I use one of those 3. If you use a paracentesis which is away from the claw, you end up creating a lot of folds in the cornea, and it becomes difficult to visualize. So the first incision is 2.8 millimeter, which is increased to 5. The lens is explanted, limited anterior vitrectomy with a 23 gauge cutter. Pupil is constricted, and an iris claw lens is introduced into the anterior chamber. Just as Dr. Mallikarjun mentioned, it has to mirror, the placement of the lens has to mirror its final implantation behind the iris. And the right claw must rest just next to the paracentesis opening on the right side. So the right-sided Clayman forceps, and this is the half inch long 27 gauge cannula. It is important to use a small cannula, which is small and rigid, rather than a long one, because long one causes a whiplash. This does not. It is rigid and it's easy to maneuver it. So go inside, catch the optic from the center with the right angle of the forceps pointing towards the cut in the claw. Position the lens at the back. You can see that the cannula is perfectly in line with the forceps, and gradually, slowly push the iris back. One push, and you can do another push. You can see that the PMMA of the lens is showing a little bit in the front. So trans-iris fixation has taken place. This means this lens can never subluxate in a person's lifetime. So once the right claw enclavation has taken place, I make sure that I pass the cannula through the paracentesis, which is right opposite to the claw on the left side. If I use the wrong paracentesis, it causes lot many folds in the cornea and makes visibility difficult. Again, stabilize the lens with the right hand and make two passes with the 27 gauge forceps, and there you're done. The lens is perfectly centered. You get in a. So if you have any questions, I can probably take them at the end. Now I come to my presentation. So this lens has completed 4 decades. And in all these 4 decades, the fundamentals and these lenses, and this is what used to result after 10 or 15 years of implantation. So the obvious answer to this problem was to go on the back of the iris. So all of you have seen these pictures now. So I'm going to show you the versatility of the iris claw lens fixed on the back of the iris. This is a patient of microspherophakia. I'm going to run through these videos. Do an anterior cap slotmy, aspirate the lens, and implant a retro-fixated ICL on the back of the iris. That's it. I don't use this because with this, I lose the bearing of where the claw is. So one side, other side, and you're done. This is secondary implantation in a patient of aphakia post-lensectomy in Marfan syndrome. Pupil is constricted. Basically, it's a repetition. Clayman's forceps. You fix one side, and you fix the other side. And you're done. This is post-op after 24 hours. A patient with traumatic subluxation, lens, the posted for phaco, but the lens was too loose. So I did an intracap right there on the table. And after intracap, large, of course, large, and then implanted a retro ICL there and then. Nothing special. It's a routine retrofixation that you've all seen. This is the patient next day. Lens absolutely centered in the pupil. And these are the endpoints of enclavation. Congenital subluxated lens. Again, anterior capsulotomy. implanting removed from the anterior side, you can do a partial vitrectomy and partial lensectomy and retrofixation on the VR table only. This is a secondary implant after silicone oil removal. So the patient had undergone silicone oil surgery. Silicone oil removal and retrofixation of the iris claw lens were done in the same sitting. Again, the ideal fixation endpoint of the iris pinch. The other side. Now this is the trans-iris fixation that we just saw and we were talking about. This means that the lens is fixed perfectly and it will never subluxate. This is a child with traumatic cataract in which cataract was removed and retro-ICL was implanted. This is a patient with megalocornea or megophthalmos in which the retro fixated iris claw was implanted, and a study has been done in which they found that implanting a retrofixated lens is much better or much easier than doing sclerofixated lenses. But there was no space to iris claw lens. Did membranectomy and anterior vitrectomy. The patient's grandmother and father had already been operated by us for similar problems in 1988 and 1989. This is the small lens. It is 4 millimeters by 2.5 millimeters. Process of implantation is just the same. So the implantation is completed. Now look at the difference in the size of a normal lens and an ultra small lens. This is a retrofixated IOL which was implanted during PKP. You can see the transfixated haptic on the right side. Pupil effects you've already seen. So complications, when somebody asks me what are the complications of retro-iris fixated iris claw lens, I start thinking, apart from occasional, once in a long time subluxation of the lens, one side, I fail to remember any much significant complication. Ovaling of the pupil is not a big complication. Transient inflammation, transient IOP spike, and CME, considering the morbidity of the patient, of the eyes that we are implanting or doing implantation of such lenses in those eyes. Okay, and now I'm coming to my third and so this lens was born in 1975, way ahead of its time, much before the birth of modern cataract surgery. At that time, there were no viscose, no magnification, no vitrectomy, no tools, no understanding of the endothelium, and the journey was rough and turbulent. We've talked about the Singworst lens, especially the lens designed by Optec. It was a huge size lens, which was very difficult to implant. And they advocated peripheral iris support, which we totally denounce. We should do mid-peripheral iris support rather than peripheral iris support. So this is the Singworst lens. You've already seen that. Long-term problems with the older lenses were lens dislocation, pseudophacodonesis, and pseudophakic bullous keratopathy, and inflammation, which was, I think, arising out of the sterilization problems, because we were sterilizing the lenses with sodium hydroxide. Even Optec was supplying lenses sterilized in sodium hydroxide, and you had to neutralize that with a weak weak acidic solution. But I guess some of the hydroxide remained stuck to the lens. So as developments in cataract surgery techniques and technology progressed, magnifications came, viscoelastic came, irrigation solutions, phaco, and most importantly, PCIOLs. The design and technique modifications continued with the ICLs, whereas nobody was doing, because this lens was actually designed to be implanted on the anterior surface, nobody was doing implantation on the backside. So gradually, the implantation shifted to the reverse. Rather than enclavating a very thin sliver of the iris, a chunky iris tissue started to be enclaved in the claw for a more secure fixation. Some people have preference for anterior fixation and some prefer retrofixation. Our anterior fixation should be done only with very small size lenses, as Dr. Kiranjit Singh has mentioned. So these are the different sizes of lenses. Now, advantages of scleral fixated lenses. Advantage is being in the posterior chamber and maybe not touching the iris. Rest, I think, are all disadvantages because a lot of maneuvering of the lens in the eye, making holes in the sclera, sutures, knots, glue, ciliary body, prolonged procedure, greater possibility of retinal complications. And as they say, out of sight, you can't see what is happening at the back. So you think things may be okay, but they may not be. With the retrofixated iris claw lens, I find it hard to find disadvantages. Yes, there's an advantage. It is in the posterior chamber. The advantage is it's a uniplanar procedure. You don't have to turn around the lens in the anterior vitreous, which is so close to the vitreous space and can cause retinal problems. The technique is very easy. The technique is very quick. There is no burrowing into the sclera, no messy sutures or knots, less intraoperative injury to the eye, and less predisposition for retinal problems. Yes, there would be some people who would have a problem about the iris hug that the lens gives on the back of the iris, but that's what the strength of this lens is. Now has been a review of I've done a review of people who have done a lot of work on iris claw lens. You can find this all over the PubMed, but I would like to mention one, and this is a study done by Dr. Srignesh, our very own Dr. Srignesh. Long-term clinical and visual outcomes of retrofixated iris claw lenses in complicated cases. And his conclusion is that the visual outcome with retrofixated iris claw lenses, when combined with other intraocular procedures, is mainly affected by the complexity of coexisting pathologies. The complications are more related to the combined procedures performed rather than retrofixation of the lens implantation alone. So it is a sum total of the situation, of the clinical situation and the lens being implanted, because generally we implant these lenses in patients in eyes which have challenging situations. So I would start to wind up by saying that iris claw lens is a fighter. It has stood the test of time. There would be very few things which you can count on your fingertips, which has survived for the last 40 years. Not over radios, not over televisions, um, not over telephones, nothing. But this design, which was designed in mid 70s, is still the same design as it was in the beginning. So the iris claw lens is not difficult to implant. It is just different. The lens is not meant to be implanted in every patient. I would not recommend you to implant this in a patient in which a lens is, in the bag implantation is possible. Make your choice based on the clinical situation, and learning a new skill is never harmful. Develop your independent opinion, and no company is going to guide you in this matter. You have to learn all by yourself and introduce this into your OT. One thing I must say, skepticism rules.
Talks we all have ever heard for a long, long time. Thank you so much for sharing your wealth of experience as well. So we'll be asking few basic questions and as well as a little bit more complex one. Let me begin the question with first with you now, Dr. Ravi. Do you use the Clayman forceps, the right and left separate for enclaving the right haptic and the left haptic?
Yes, I use for the right haptics.
And especially in an eye which is vitrectomized, it's already is hypotenuse, the visibility is a problem. But we never saw anything of that in your videos. Now, do you just share some of your tricks like how to avoid these corneal folds and collapse of the chamber in a vitrectomized eye?
Yes, a few things Dr. Ravindra also mentioned. You have to tiptoe inside the eye. You should not press on the posterior lip of the incision with your forceps. The Clayman forceps is very slim as opposed to the other forceps. Now the vertical forceps which Dr. Ravindra was using, uh, when it opens quite a bit, and there's a fish mouthing of the incision. Whereas with the Clayman forceps, the incision does not fish mouth that much. The other thing that I already told you is uh, the other thing which I already told you is that the enclaving cannula should be in line with the cut. If it is slightly up or down, you are going to bend the cornea and create folds. Third thing, the enclaving cannula should not be longer than 4, and you will not have any folds and you will not have any problem.
Slightly dimple incision.
Thank you, sir. Thank you so much. And this pseudophacodonosis, we often see pseudophacodonosis in these iris claw lenses. Is it surgeon dependent or is this eye dependent? And is there any trick to prevent this excessive pseudophacodonosis?
Actually, if you see there, but it does not disturb the patient.
So if there is some amount of moderate pseudophaco, we do not be alarmed. So
no, there's nothing to be alarmed about.
Yeah, as long as the patient is not complaining, he doesn't usually complain.
No, none of them complain about this.
Okay. And second, if we have a situation where we want to remove the diode, if we have got into a situation,
hold the lens firmly on the center, and with the cannula, press on one of the longer limbs of the claw and push it on the back. Generally, it loses its tension, and you can free the you can free the lens from the iris and bring it to the front. Second is, if you find this difficult, hold the lens with the Clayman forceps and introduce a very thin Warner Caesar, cut the haptic, and you can bring out the lens very easily. So it's not difficult. You just have to sacrifice the lens.
There is one of the common comments which we see on the podium, like, many people just say that, you're enclaving the iris pigment epithelium, and this is the reason it's going to cause a lot of cystoid macular edema, and they accuse, because it's in close proximity or hugging the iris, they feel that, it is responsible for causing cystoid macular edema. I want to know the experience of all the panelists here who have used these lenses for decades. In an uncomplicated scenario where vitreous is not the cause, you've done a nice vitrectomy and just the lens is there. What is your experience as far as the incidence of CME is concerned? Because this is one of the common fears which has been thrust upon the mind of the surgeons.
I would say that, you can't see where they have passed the sutures through the ciliary body. and skeptics are always going to be there. You know, I've been facing these questions for the past 35 years. This lens fixed either in front or at the back of the iris does not cause CME. And um, as that reference of Dr. Srignesh also mentions, that it is the sum total of the patient's situation which can cause CME, right? Uh, Scleral fixated lenses, how much they mess with the ciliary body, nobody knows because you can't see it. Out of sight, out of mind. Now, this is visible to them and everybody is talking about it. When they make 2 or 3 or 4 holes in the ciliary body and the sclera, why don't they talk about it? What is it about that they like and they hate about this?
Extremely valid point. Dr. MSR, sir, I don't think you have experienced any CME with these lenses.
Absolutely no. CME, we reviewed after this question came up last time in one of the meetings. We reviewed all our cases, and there's no incidence of CME. I mean, the other causes which indicated the implantation of iris claw lens, if they managed well, like doing a good vitrectomy, and seeing that the vitreous is not connected not only to the wound but inside also. It should not be connected to the iris claw lens itself. We have no increased incidence of CME when compared to any other series of patients. So CME attributable to the weight of this lens is around 12, 13, 14 grams in air. In the aqueous, in the fluid, it's going to be even lesser because of buoyancy. It's hardly any weight. You don't see it, hanging on. It's not a heavy thing that's lying down. And of course, the iris is attached 360 degrees. When you are attaching a scleral fixated lens, it attached at two places. So this is through the tissue of iris. The attachment is a natural attachment to the scleral spur all around. So the distribution of weight on the thing is hardly anything. And what I do is after anyway the stormy surgery is managed by an iris claw lens, and then I would use the post-operative drops. Steroid I'll stop at the end of 1 month like any other case, but flurbiprofen is my favorite medicine in all these difficult cases. I continue twice a day for 3 to 4 months time. So I have not seen any CME at all clinically. We have not done OCT studies because nobody had defective vision explainable to the possibility of CME in these patients. I have not done OCT, but then clinically there is no increased evidence.
Dr. Mallikarjun, you mentioned, I think you didn't have any raised incidence of CME in your live series. Dr. Kiranji, sir, can you just get your video ready to demonstrate iris anti-inflammation of the iris?
Doctor, I didn't get your question, Doctor.
Just cystoid macular edema. You have got a large series. Also have
see the planned surgery where Dr. M.S. Ravindra, Dr. Ranjit Singh were discussing. If there is a good vitrectomy and you have implanted the iris clothing properly, we never think of cystoid macular edema. I mean, it doesn't come to in our mind that there will be increase in the cystoid macular edema or something. But if it is something, if the indication is something different, like traumatic cataract or a pediatric, then definitely it is as good as a regular.
Dr. Pradeep Reddy has a question for the panelist. He's asking where convex surface of retrofixated IOL should be. He's referring to something difference between concave curvature facing anterior versus posterior in retrofixated iris claw lens. Dr. Raviji?
Yeah. Actually, you can implant the lens either way. I generally prefer implanting the convexity forwards, but you can implant it on the back also. I use plano convex lenses. If I turn the convexity backwards, I have to adjust a little bit for the biometry for half a diopter because of the convexity going back. Otherwise, both ways it's the same. I've implanted a few vaulted lenses with the convexity backwards, And again, the only change that you have to make is a little bit adjustment in the biometry. Otherwise, it doesn't make any difference.
Which company, Indian company lenses do you use for retrofixation? And do we need to order, like, biconcave or plano-concave? How do we order them?
Generally, all of them make plano-convex lenses,
Okay.
right? So the vaulted lenses, I'm not aware who's making them on a regular basis, because the vaulted iris claw lens was initially used for phakic implantation, not for aphakic, because you don't need the vault.
So all of the Indian companies which make iris claw lens, all of them are equally good?
All of them are good. But the only thing that you make sure is buy one lens from them, open it, and try the strength of the claw. If you think the strength of the claw is correct, buy that claw. If it is too hard or too soft, tell them to make it right, and then you buy it from them. Don't just buy all the lenses from them.
Thank you. Dr. Kiranjit, most of us are used to the retro fixation of the iris, the lenses. We don't use anterior fixation much, actually. So I'm fascinated by how you thread the iris into the claws, actually. Just actually show us in a quick video, share some few practical tips there. Most of us are worried about dropping the lens back. If we are able to fixate the anterior claw lens, beginners would find it much more easier. Please share your tips on that.
Okay. So I think already told that for the beginners, they should be passing the suture through one of the claws so that the lens doesn't fall down. Now coming to the anterior fixation. Actually, we use Heal-On for this purpose because it gets washed out easily and doesn't cause any reaction in the eye postoperatively. So I give a small incision. If the breadth of the lens is 3 millimeters, it is enough for me to slip in the lens in the anterior chamber. So under the Heal-On, I slip the lens vertically, then I make it horizontal. This is McPherson forceps, horizontal McPherson forceps. So I'm showing it in slow because that saves time for me, or back which is passing through the claw, taking along the iris, and I'm taking care that the tip doesn't injure the iris. That blood is from the incision line. So I think the other side is going to be a little clearer. So I'm holding the lens with a vertical forceps. So there goes the needle, 26 gauge needle, and I use a straight needle. I don't bend it. So I engage the iris and I pass a little thread into the claw. Then with the back of the iris or the shaft of back of the needle or the shaft of the needle, I pass more iris in the claw. This is the first time. It has never happened. Perforation of the iris has never happened, and this is actually a micro movement of the iris. If you do a gross movement of the iris, that is going to injure the root of the iris. That is going to cause bleeding. So it has to be very micro movement. It should not be a macro movement, because in our learning from the iris root, so there
Is there a
no
method
way
to
to
choose
choose
it?
it. Just the size of the eye is going to give you an impression that I need this type of lens. We have lenses 7.2 millimeters in length into a 4.5 millimeters breadth. Then we have 6 millimeters into 3.5 millimeters. Then we have lenses 4 millimeters into 2.5 millimeters for microcornea. So the smaller the eye is, the smaller the choice for the lens is going to be.
There's a question for Dr. Ravijit. Dr. Adio is asking, where does the convex part of the IOL face when inclavating? Is it the retina side?
No, the convex side of the IOL faces the front.
Any question
Well,
on
now,
that? And
yes.
There is a question by Dr. Jagannath Buramani. Which company makes lenses which give marks on the optic? Dr. MSR, sir, I think you had shown this clip.
Yes, I think any company can make it. It's a PMA lens, marked lens, if the pupil is very small. But nowadays they have stopped making it. If you withdraw the lens towards the side which is not being enclaved, uh, then you can see the roots of the or pillars of the haptic, and then gradually take it towards many lenses. Can all companies can make that lens.
There's another question here. The ideal way of placing the side ports to tuck the iris claw. Dr. Ravijit Singh sir, you told that you make only one side port on the right side, and you make three or two on the other side. Just share some practical tips on what is the right way of making these side ports. Do they have to be limbal, clear corneal, or slightly clearer?
Actually, they are more or less limbal only. But these side ports I made, the size is 0.6 mm. That's the size of the diamond knife that I have. And these side ports should be made radially, not in any other direction. Because if the direction is different, once you take your cannula in and then you turn it, you'll again make folds in the cornea. So I make one on the right for the first enclavation. Then, depending on where that enclavation has taken place, I let the left claw of the lens rest on the iris so that it faces the three paracentesis openings on the other side. Then, depending on which paracentesis opening offers me the best centration, I choose that and enclave the lens on the left side.
So you mean radial? I didn't get the word radial. Do you mean how do you mean radial stab incision? There?
Radial in the sense that the direction of the knife should face to the center of the pupil. It should not face downwards or upwards, because if and second is the length of the paracentesis incision should not be very long. If the length is long and when you pass your cannula through it, again you're going to cause folds.
I think that's an excellent point.
The track should be small.
Yeah, yes, sir, absolutely.
One more.
Yeah, go ahead, Mallikarjun, go ahead.
One more. Beginners, they'll have a difficulty whether after in enclavating both sides, whether it has been enclavated or not. How to confirm it before taking out the grip. That is because they'll have if I leave that grip, it may go down. So what you have to do is gently push slowly down, once down, and see both sides of the iris. The both side of the iris, you will see the deepening, and the iris also moves along when once you push it down, iris also moves both sides. So if it is not enclavated one side, you won't see that resistance that side. So that's how again you have to take it out on the antechamber and.
Actually, in the beginning, you are a little skeptical as to whether the lens is fixed properly or not. After you've done a few cases, the feel of the hand is in your fingers is that you've fixed it well, and if there is a trans-iris fixation, then there is no question of bad fixation. So it's just for the beginning 5 or 10 cases that you need to confirm. Otherwise, there's no problem.
Yeah, I think these lenses are not very expensive. The best is to take it, use it under microscope, take a very thin cloth, maybe a transparent, very thin cloth, muslin cloth or something like that, and try to enclavate it. So before I started using the 27 gauge cannula, everybody were trying to, so the picking is with a sharp needle, either a Sinskey hook or a needle, as he said. But while you're putting retro lenses, you have to actually push the iris downwards. So people were using Sinskey hook at that time. So I said, why not use a cannula? Sinskey hook has no role at all to play when you want to push it. So a very fine cannula really changed the game. There is no iris damage at all. Before that, the hook used to damage the iris the way I was doing it when I started doing it. But the cannula, when you push it down, and it's a very smooth. And when you're pushing it down, at that point, see that the lens is in the center. If the lens is eccentrically, you will have an eccentric lens. Mind that you bring the lens to the center and don't do anything except a vertical movement with the cannula downwards. So there is no lateral movement at all. So this is very important to ensure that the lens is centered well. What I do is when I make the Ravijit said a beautiful way of having the option of three. What I do is when I do the side ports, when I create a side, I create one side port and keep the length of the MBR across the cornea. If that's the cornea, I keep it across the cornea. Even if it slightly eccentrically is there like that, you can immediately know you're not exactly opposite by looking at the cornea is divided by the instrument into half and half. Exactly at that point, I'm going to make another one so that the two ends of the entries are at the same long meridian, longest chord of the eye, that is the diameter.
Yeah,
So
actually, I make the paracentesis openings in the beginning because after you have made the main incision, and if the eye becomes soft, it is little difficult to make the new paracentesis openings. That is why I make them in the beginning only.
in a planned surgery, you can, but most of us, like when there is a problem during
Yeah,
surgery,
of
that's the
course,
time.
of course, of course.
Then you have to form the chamber and then make it a little firm and then do the
That's right.
entries.
Agree with you.
So can I
To
make a
make the
comment?
tunnels shorter, I've explained it. I don't know whether it was clear. If that is the cornea, if that's the cornea, and there are various ways you can take the direction of the MVR. If you take the MVR in that direction, it's going to be a long one. If you take in that direction, it's even long. But if you take it down there, not only it's towards the center, but also towards the center of the pupil, down like that. So you'll have a very short length of the tunnel, and when you pass the cannula there, when you're passing it like this, there are no folds in the cornea. So this is not only go medially to the center, but also downwards as you are creating the MVR. This one has helped me to avoid the wrinkling of the cornea when you're actually passing the cannula onto the iris.
One more question, Dr. Ravijit. What are your tips to minimize the ovalization of the pupil? Dr. MSR sir touched on it a few times. Please share your thoughts on it.
Ovalization would occur if the size of the lens is big and the eye is small. If you choose the lens on the smaller side, you will never have any ovalization. Never. And you have to try to fix the lens just outside the colrate. If you claw the lens on the colrate or inside it, you're bound to have ovalization.
Is PI necessary
Okay.
in all iris claw lenses? One of the questions.
I always do a very small PI. I don't want to take any chances with it.
Dr. Deepak, regarding doing paracentesis in hypertonous eyes. See, one more thing what you can do is at the site of paracentesis, you will give a counter pressure at the same side. You take a colibri or a hold the conjunctiva at that side only. One side you pull it and make a paracentesis so that you won't have the much of the folds there. I think.
Yeah, I think that's an excellent point. Anybody has any more questions?
I have a question to Dr. Ravijit.
Please, sir.
In a normal eye, Dr. Ravi and Kiran, in a normal eye, everything is normal, no micro, no maglo. And what is the ideal size of the optic size and the overall length of the iris claw lens that you would prefer to fix it on the back of the iris?
7.25 multiplied by 4.5.
4.5 optic size, 7.25 is the
overall length.
What is the disadvantage of a smaller and larger than that?
No, in a normal sized eye, this lens looks perfectly good. The size of the optic is good. Everything is fine. The moment you start making the lens bigger, ovalization and other problems will creep in. You can implant a smaller lens in a big eye without any ovalization, but if you implant a bigger lens in a small eye, you'll definitely have ovalization.
Fine. The second point is because of the standard PC lenses are all 6 mm optical size. When you suggest a 4.5, will they have any night vision problems like glare while driving? Because people is going to go beyond the edge of the lens.
You see, most of the lens implants, the retrofixated or the anterior fixated iris claw lenses are done in patients who are in which there are situations are challenging. For them, it really doesn't make that much of a difference. And even in the posterior chamber lens, almost half a millimeter on either side is covered by the capsule.
Correct. Yeah.
So the
Yes,
effective optic in that case is also 4.5 millimeters only.
Okay.
Sir Ravijit sir, I
What are
have
the
one question.
complications you have seen? Like last year, with your expertise of 40 years of so many decades of use, today, what are the complications that you would see? The older complications, will let us forget about them.
Will you believe me?
Huh.
Zero.
I would believe you.
Zero.
Okay, good, great.
Sir Ravijit sir, I have one question for you, sir.
Yes.
You don't prefer biconvex lens because many companies are making biconvex lenses now because the really making is easy.
Biconvex iris claw lenses,
Yes, sir.
it doesn't make any difference.
Yes, yes.
It
Because
doesn't really make any
what
difference.
you are using is a biconvex, which I mean.
Which company are you using, Mallikarjun?
It's excellence.
Excellence. Okay. And they make only biconvex, or they have a plano-convex
They
model
can
also?
make. They if you want
Feed into that machine, I think we'll get the right. I'll calculate it.
So for the interior fixated iris claw lens, we use an A constant of 115.5, and for the posterior fixated, we use it 117. So that works.
We calculated the A constant of our series. It came to around 117.4. But the lenses I used, I've got an angulation, mild angulation. Like if that is the
Angulation backwards.
but why I prefer them is optic is little behind the iris plane. I'm
Yeah,
theoretically
exactly.
probably there is.
So with the lens that we use, plano convex with the convexity forwards, 117 does the job.
Okay, fine.
So if I implant a lens with convexity backwards, then I add half a diopter to that.
It comes to 117.5.
Yeah.
Correct. That's what our calculation. He has shown me his entire PowerPoint presentation. How the trade can, the supplies that we get can be so erratic, and that can be the cause of failures during surgery, like creation of task, creation of endophthalmitis. You should update it now.
Actually, things have become better now than what they were many years back. You have much better standards of fluids which are coming. Much better. We are using disposable cassettes for cataract surgery. Our sterilization standards are much better. We have better indicators. We are much better equipped now and much better understanding now than we had 20, 30 years ago. So the problems are few, but eye surgeries is a unique kind of a surgery in which so many cases are operated at the same time, and we end up reusing some of the handpieces, some of the tips, some of such things, which, if goes bad, can cause multiple problems in multiple patients.
Yes,
Especially in our Indian setting or other third world country settings. If you change everything.
Next thing I should definitely ask you is when Daljit Singh was around, it was an aura. It was the way innovations are seen everywhere. It's are kept in place. There are 100 points you can pick it up every day. So how do you feel the absence of Daljit Singh, the same drive, the same motivation, the same innovations are continuing there?
So there is so much that we are learning every day and incorporating in our daily use. And there is so much from the past also that we're using. For example, stainless steel sutures. We just can't live without them. Iris claw lenses. I can't think of a cataract OT without iris claw lenses to back us up. So these are the things which have got inculcated into our system. More important than finishing it in 5 minutes less. So many years ago, a person from AM Mohi came to me. He said, so we have introduced this phaco machine. This machine does surgeries faster than the older machines. And if you start using this, you'll be able to go back to your home much earlier. He doesn't know doctors are so stupid. If they can do something quickly, they will add 5 more cases to their list. So it's not that important to do it fast. You must enjoy.
which is very close to my heart, and I want to share
Sure,
that
sure,
with you.
please.
So and there was cataract, and vitreous was also mixed with the cataract. So she came to me 3 days later. I told the anesthetist to just prepare the patient for immediate repair. So I took the iris hooks. I first I did some suturing of the cornea. Then you can cornea. And from the very next day, she was advised to start playing video games with plus 10 diopters of spectacles, keeping the other eye closed. So she was doing playing these video games for the next 1 month, and um, after a month, I implanted this lens, uh, and you can see the amount of iris I have put in the eye. And after 24 years, 21 years, now she's 25 years around 25 years, and presently she has needle or a knife or a scissors, so it has a role in such children also. So that is what, and the eyes perfectly straight. It has not gone divergent or convergent. It's perfectly straight, and she's using those big sized corneal scleros contact lenses, and her vision is 6 by 6. This is wanted to share with you.
Thank you, Dr. Kiranji, sir. That was immense popularity among the people. They want to learn. There's a question here asking Dr. Ravijit, do you have fellowships or training programs for iris
Well,
claw
we
lens?
don't
Somebody's asked.
run a formal training for iris claw lens, but it's a pleasure if somebody wants to learn. We'll definitely teach him, no problem. And I say that my tryst with iris claw lenses started when I was in school with my father, and he started making these lenses by first started making the raw material. The raw material was monomer, which he collected from a friend, dentist friend's office. So first we used to make polymer out of that, plastic or PMMA, then make the lenses out of it. And the lens that you saw, which was dislocated in one of the videos that I showed, was probably made by me only 25 years ago.
Wow.
So I think I may have my mother, my father, and me. We may have made like 50-60,000 lenses with our own bare cloth and try to pass it through the claws. You can either do that, or you can you can shred a piece of cotton and try to doing the same through the claw. And this is the only way to learn it. You have to hold the lens firmly, gently yet firmly. Number two, you have to stabilize your hand which holds the lens so that it doesn't move. And then with very gentle stroke of the right hand, you have to enclave the iris. Whether you have to do it on the anterior person sit on those tired machine and you will not fall. It is you get you. This is experience. This is training. So similarly, before you try it in the eye, you must break 10, 15, 20, 30 lenses. Be absolutely confident in handling the lens, and then when you try to implant in the eye, you'll have no problem. I can assure you that. And these lenses, as Dr. Ravindra said, they're so cheap, you won't even believe if somebody tells you how cheap these lenses are, and they're value for money. They are gold. Yeah, they're worth every.
What I do is I do not pass the needle like that to separate them. I just move one of them, see that it's moving. Then don't pass the inside that. If you
Exactly.
pass inside, the tensile
So
strength will go
the
away.
plastic, yeah, the plastic memory. You'll see that there are strain lines which appear at the end of the haptic. So you should not pass it too many times.
That's what, even when it's inside the eye, see if you are pressing instead of there, if you're pressing this one, there is a chance that it may not hold the iris well. So if you pass exactly at the slit there, I mean, it will keep the strength of holding the iris. So
So
this
actually,
is one thing.
there are two technologies to make PMMA lenses. One is by lathe machine, and the other is by compression molding. The lenses which are made by compression molding, they are the ones which used to be made by Optic and which Dr. Dalit Singh also used to make with. These lenses will have very flexible haptics, but the lenses which are made by lathe will have stiff haptic. It'll have a uniform tensile strength. So you could measure that with a micrometer, and you should be happy with that. 0.17 or 0.18 millimeters.
Do we have any more questions here?
Dr. Ravi and Kiran, is it possible to make an opaque iris claw lens, like
Of
for
course,
example?
of course. The same to make these kind of lenses which were opaque to be implanted in patients who had diplopia.
Okay.
And also they used to make these lenses in for albino patients. So it was an opaque lens with a small opening in the middle which had a transparent optic. We used a few of these lenses in albinos, but uh, after a little while the optic would come out. The haptic would stay there and the optic would slip out. So it wasn't fixed properly. After that, we never used them.
The other thing is, if in a pediatric patient you implanted a lot of them, how often you change the lens? You remove the lens and put it correct, like there is a progression of
Implanted lens. It's a regular thing, routine thing
What
for
about
us.
do you implant toric IOLs, toric iris claw
No,
lens?
we haven't implanted any toric IOLs, whereas Optic sells toric IOLs also, but they're not available here.
Okay. Okay, good. I think it's a very, 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 very fruitful day for all of us to have discussed iris claw lenses. And I think these are the ones which are most practical.
People are using, don't want to speak.
Correct.
That is the issue, because they don't want to get the backlash of somebody saying, "What are you doing?" You know. So that is the only thing. Gradually and slowly and gradually, I've been speaking about these lenses for almost 35 years now, and people are picking at the moment. There is no replacement in sight.
One small
Ravi,
comment.
there is a tendency in Israel and many of the countries, developed countries, instead of using iris claw, they suture the IOL to the iris. How do you rate?
So
Okay, you're right.
on the back, why do you want to go through with all those sutures and knots and everything when you can do it the easy way? Why to catch the ear from the other side when you can catch it with the other hand?
Good. I just wanted that message to be conveyed through you.
Small comment. The where I'm sitting here, it's South India, South Karnataka. We just now, 20 minutes back, we had an earthquake here.
Is it?
And I was unmoved because I was so much involved in the discussion that I was unmoved. My wife and all, they came, what we're doing here? There is an earthquake outside. Just there were a lot of shakes I could appreciate, but because I was so much involved in the discussion, you can read it in tomorrow morning in the news. I am very fortunate to participate in this webinar. Thank you all.
When everybody's interested, everybody. We have been doing it for almost 35 plus years. So it feels good when you can transfer what you know to other doctors who wish to start this, who wish to do that. And Dr. Malikarjun showed some beautiful beautiful video and beautiful cases that he had done. And that's the way to go. You have to realize the full potential of the iris claw lens, and the possibilities are endless, limitless with this lens. So I was actually joking, my when we operated on my father for cataract, one eye operated and the other eye Dr. Kiran operated. I said,
Malik,
Okay, we had the privilege of inviting Dr. Daljit Singh and gave him the gold medal oration in in Bangalore Ophthalmic Society. That's a
yeah,
dream come true for us. Such a simple, humble man, straightforward. He does not hesitate to express what he thinks is right. So many things, and it is said that he was born he was the first person who took stereo photographs using a Nikon camera, Nikon or Canon, I'm not sure, on the slit lamp, and he used to show so many.
the first time he started taking was with a camera that he was fascinated with 3D photography right from the beginning.
Yeah, yeah.
And I still have his collections of cameras. There are 32 in all, from the smallest to the biggest.
D slit lamp, that's got the port, and he
Yeah,
got hold of is it Canon or Nikon? I'm not sure.
it's
Nikon
Nikon.
camera, if I'm right.
Nikon.
Nikon. So Nikon people came to his place, saw the slit lamp, and adopted the Nikon camera to suit that. See, the
Yeah,
engineers from there came, and he used you can have a beautiful 3D picture with a still
yeah.
camera.
No, his photographs we used to post on Asian ophthalmology that really inspired me to take up anti-segment photography. That all the credit goes to him because, and he continued to take good photos even with his phone. Amazing photography with the camera phone itself,
Yeah.
and he was one of the main inspiration for me to take up anti-segment photography. Well, so
And,
all
and you
remember.
know, and you are doing that so well.
Yes. The other thing I should
Thank you so
recollect and
much.
tell is the way he was examining patients. There's a queue of patients, about 100 people standing in a queue. He takes 1 or 2 minutes to see a patient. Within that time, he examines. There are two takes. So if the patient has to get up himself, it takes time. And all is done in a minute or two. Everything. It's a dream. I've never seen such organized person like Daljit.
Okay, I think nobody wants to mention
The
that.
time
I
at
think
this
we
time
discussed a
of
lot.
the late evening to be with all of us. And thank you for listening to whatever we had to say, whatever we had to share.
Sir, sorry, I know it's kind of late, but I just wanted to know if like there's no capsular support or
It's not a matter of doing quickly or not. You just have to do it right. You have to hold the lens firmly so that it doesn't drop back, it doesn't slip, and you just it's like you are crossing a deep cliff with a ladder. You should not see down. You must make sure you are stable. Or pass a 10-0 suture through one of the haptics of the lens and let it stay outside. So even if you drop the lens, you can always pull it out.
okay, okay. Thank you so much, sir. Thank you.
Are there any more questions around? We still have around 70 people still logged in. It's 11:15 now. Still 70 people are logged in.
No, the iris will not go through unless the
Okay.
needle goes through. So the needle goes through and then you bring the needle out. I can share that video once again.
Yeah, I saw that.
Maybe just give me a moment.
I would like to show it here. Okay.
Okay, charger there.
Yep.
Maybe you could see the other side also.
Sure. Thank you.
The trick is you'll have to go down to push the iris, and when you remove it, don't come back.
Yeah.
Draw it out of the eye. Draw it
Exactly.
out of the eye.
Absolutely. Absolutely.
Kiran, I should thank you because it all started with you. You
Is
sent
it?
a
I didn't know that.
you yeah, it started with him. He sent a message to me with his special the opaque segment video. Then I asked him, why don't you present this in our meeting? And he readily accepted. And he said he said let us do it along with Ravi. So that's why both of you are here. I'm amazed.
Ravindran called Ravi more. Ravi doesn't come out of the fort. Kiran we always see.
Yeah, that's true. We want to see Ravi.
Is that Dr. Saha?
Yes. Ravi, thanks a lot after a long time.
Yeah.
And lovely, but you have stopped coming out.
Yes.
Yeah, we would want to see you more, sir. Definitely. I agree
Sure.
with sentiments.
We want to see Ravi, that is one. And to carry forward Sir's mission, you must put on regular something, somewhere. You choose your area where you want to post your things. You have so much of material and so much of teaching.
That's right.
So carry Sir's flag higher and higher.
Thank you, Dr. Saha.
We always love to, because we see Kiran quite often, but I am seeing you after, I think, ages.
Yeah. Me too.
So at least post there, we'll be elated. Like
Sure.
this, you are not out of your fort, but we are seeing you.
But Dr. Saha, you're also nowhere.
Reality and ophthalmology that carry forward Sir's dream, and he was the best educator.
I think very, very, fruitful meeting. I think we can
Yes.
end it, Dr. Deepak.
Yeah, yes. Dr. Dev, Dr.
Yeah,
Dev.
It's
Nice seeing you, Ji.
I opened up my video just to meet you.
मैं देख लिया थी तुम.
वही मैं देख रहा हूँ जो बॉस को मिलना मुश्किल हो गया.
मिलना तो मुश्किल हो गया ना अब ये कोरोना के टाइम में. तो
नहीं अभी कोरोना टाइम में ठीक है, बट
हमें तो आज
सब
का भी कोई जवाब नहीं.
जो टाइम बचा इसीलिए नहीं. This is from the chief. This is the chief scientist of the wactching. सर होते तो जरूर करते.
और वो जरूर इसके बारे में कोई ना कोई कहानी निकालते.
Ravi, I remember one. Like I said, I'm going by car. You have a driver? No, sir, I'm driving my own car. Okay, wait a minute. I'll tell you something. So then he said, the two ultimate luxuries on the face of this earth are to be able to drive your own car and live on the ground floor of your own house.
That's right.
and
the second one?
And the second one was to be able to live on the ground floor of your own house. Ji Singh gave his talk, and I remember the audience was very aggressive in that hall. It appeared as if some of them might eat him up, and but he held his ground, and he spoke very smoothly, confidently, very short sentences, spoke very little, but conveyed everything. And then somebody said, any questions? Everybody has the Singh was lens, but I have another comment to make. lens may be worst thing, but there couldn't be a better thing. So after that session, Dr. Daljit Singh came up, saw my tag, Acha, Taliwal from Naba. Yes, sir. That was a nice comment you made. How did it occur to you? Sir, I just couldn't take it.
Sir came to AIMS as a national workshop, mesmerized to see that fantastic, I think, short time surgery and taking out the lens from that bottles and putting it in. And I was assisting him, second assistant, he had his own assistant. And while he was going out, he gave me a bunch of the sutures. And I think 20 years I kept them for a long time, but then sitting houses somewhere I missed it. And I had so much of memory with him, innumerable, beyond this place. But he's always inside, always with me. And I think I'm the only one. Rabijit may remember. It was 2006 or sometime like that.
You stayed with us for many days.
I came. I came to a meeting in Amritsar. I stayed in a hotel. I called him because wherever I am, we had a regular talk with him by phone, by net or whatever. Then he came to my morning OT, the hotel. तुम इधर क्या कर रहे हो? पैक करो अभी. और अभी तो इधर ही हो. नहीं आपको मिलने आऊंगा. नहीं तुम पैक करो अभी. He from there took me to his home, and I was his another son, and I was assistant to Ravi's wife because my interest primarily is retina, so whatever. So we had a very good time, and Ravi showed me everything, their farmhouse, this and that. So it was a very, very memorable time for me. I think it was about 2 weeks or nearing that.
About 15 days. Yeah.
After 2 days, it became 2 weeks, I think.
Yeah.
So that's what I'm telling you. So it's the best time we sat. All the conferences we were together, but in his house, in his OT, in his leisure, means it is really kind of a hero worshipping at its best. In the morning, all the meetings in wherever we have met, where all those things and so many things means it's innumerable. And what should I say? The Sony had a camera which had a macro. Nowadays, all the mobiles have it. That macro had very good photography. So I had one. I used to put photos from there, and I showed him also. Then, but that time they removed that particular model, and they removed that particular feature. Then he was searching from the old phones. I said, sir, in my old phone, so this is gone. This is not that good. So who knows? You will spend that money and you'll never know that you'll get a good one or not. So that was the enthusiasm. And I am the only one, I think, I did that glaucoma surgery with under him. So great. And we will learn it.
Sure.
Nowhere in India so much of clinical data. I have traveled everywhere.
Thank you, Dr. Saha.
Dr. Dev.
You might have left, I think.
Yeah.
Maybe.
Yeah, I would like to, on behalf of the Karnataka.
Dr. Dev, yeah, your network on. Are you on?
I am on, but there's some network issues, so you can edit it.
Please go ahead.
Yeah. On behalf of Karnataka chapter of the ISMSIS, I would like to thank the
experience for all of us. Thank you, Dr. Kiranji, Dr. Ravi, and for enlightening us about this thing. And it has been one of the most appreciated and most widely attended meetings of our weekly meetings. We have every week meeting, and this was a session dedicated to iris claw lens. And thank you so much for sharing your time and your tips and your experience, which is incomparable. Both of you have done these lenses, use these lenses for decades. And my thoughts will be echoed by most of us here. I also like to thank Ravindra sir and Mallikarjun to contribute in this and share their experience. And at the end, also all the delegates who are up there until now, almost it's 11:30. Thank you so much. And Dr. Kiranjit and Dr. Ravi, be prepared to attend one more meeting, maybe a few months down the line. Okay. Good night.
Thank you. Same to you.
Thanks, Dr. Saha. Nice appearance.
Sir, my pleasure.